I'm going to spend 2-3 minutes just to introduce what you're going to hear, and then I'm going to sit down. So, so this is the NIH Clinical Center. This is the about 300-bed research hospital where you are familiar, for those of you who have come, where we keep you for about a week. Really, all of the work that we've done through the years has happened through an amazing group of people that span close to 12 NIH institutes of different subspecialties. And this is not a fully complete list, but it gives you the sense of how we've built a community of physicians, scientists, and scientists, all of whom now have seen with us over 120 patients. That is the same endocrinology group, the same every subspecialty group has really gone through this exercise. Most of the thanks really go to the group within my group. So I think Elise as the driver, Monica and Whitney as well, and then you met Greg already, and then Leka and Vasily, some of whom do more bench work, but you don't see them when you come. So what happens during that week, for which we'll talk about 3 items today, is that we decided early on that in order to understand a rare disease, we need to understand all facets of it. So everybody gets a very uniform and systematic clinical evaluation that includes all of these subspecialties that you will see here, so that when we ask the question, what is normal or abnormal within APS1, we have a control within that group that has or does not have that entity, and not a healthy donor or a healthy individual without APS1 otherwise. At the research level, everybody gets a whole exome sequencing. Greg alluded to that. That relates to not only understanding AIR itself, but how other modifiers or gene variations might affect why different patients get different diseases. We're now moving to whole genome sequencing for several patients, especially those that we don't have biallelic AIR mutations. And everybody, as you well know, get uniform blood, urine, stool studies, imaging studies, and we do a lot of procedures that are clinically indicated, which are listed here. And when we do that, we also perform research studies so that we understand better the disease in its facets. We started with the first patient in mid-2013, and we have now over 120 patients. This has grown way beyond what we thought it would be, and it's been extremely exciting. I would say now over 20-25 patients are from around the world. As far as Australia, a lot of countries from Europe, the Ukraine, Middle East. So we have a lot from South and North America, but not exclusively. So what we'll hear over the next 40 minutes is Mukil telling us about the intestinal problems in this disease, Theo telling us about the liver problems, and Elise telling us about the lung problems. Again, entities that are not part of the triad, that can happen early, can have devastating implications, and how through this journey we've been able to understand these diseases better and in some cases implement successful therapies. So with no further ado, okay.
Hi. Thank you for allowing me to speak today. So as Michail mentioned, I'm going to be talking about the intestinal manifestations of APECED or APS1. Just some brief disclosures. As was mentioned, I'm an employee of the U.S. Food and Drug Administration, and I'm kind of continuing to participate in this study as a volunteer. And what I'm saying here is not the FDA's position, which is kind of obvious. But all right, so let's move on. So as part of the study that you all know about, we've found that intestinal dysfunction is very common. So when I looked at the data, this was the cutoff was a little bit before, so we didn't have all 120 patients, but we had evaluated 74 at that time when I looked at the data, and 80% of them, which was 59 of them, had some evidence of intestinal dysfunction, and that was that was a lot. So, and how did we define intestinal dysfunction? We said they had to have symptoms of chronic diarrhea, chronic constipation, or a history of either one or either one in the past. And chronic here we defined as having symptoms for at least 6 weeks. And out of those 59, the breakdown here shows, a lot of them, 29 of them had chronic diarrhea, 16 with chronic constipation, and 14 had a history of both. And as was mentioned earlier, sometimes this can be very severe, and some patients were losing weight and couldn't eat and had very severe symptoms. So what are some other symptoms that we noted besides just the diarrhea and constipation? These are some of the symptoms we found very commonly, including abdominal pain or abdominal cramping was in 61% of the patients. 73% had symptoms of abdominal bloating or distension. 61% reported very unusually foul-smelling flatulence, and 60% had stools that were either floating in the toilet or greasy. So these symptoms together, almost all the patients had at least one of these symptoms. So it was kind of a constellation of symptoms that we noted. The other thing we found is we looked at how early the symptoms were present, and this was kind of alluded to in the earlier talks, but we found that the median age of onset was 5 years, so meaning half the patients had some symptoms of intestinal dysfunction before they were 5 years old, and some patients as young as 2 months old, as you can see here. And also, about half the patients developed these intestinal symptoms before they developed the classic diagnostic triad. We also found involvement of the small bowel in our studies, which I'll get into the specific studies in a minute, but we found 42% had fat malabsorption when we checked the stools for fat, meaning they weren't absorbing it, and we found elevated levels in their stool. 50% had low zinc levels, suggesting they weren't absorbing it from their diet, and then 2/3 of the patient had an abnormal iron absorption test in which we checked iron levels before and after someone took an oral tablet, and we expect a certain amount of increase, and if they didn't go up at that threshold, that was abnormal. So these three things kind of go along with the small bowel. That's where those things are absorbed. And then we also found a smaller subset of patients with elevated stool markers for inflammation, including calprotectin and lactoferrin. So, very early on in this experience, we wanted to try to get a better understanding of what is the etiology. Why do these patients have these kinds of symptoms? And as Dr. Lionakis mentioned, we took a very broad, comprehensive, unbiased approach to evaluate everyone who came forward to see us, including the gastroenterology consult team and our consult group, and all the patients went through the same battery of stool tests, looking for fat and other things, including pancreatic elastase, looking for pancreatic insufficiency, which I'll mention in a minute here. They all had the same blood tests, looking for low levels of different minerals and vitamins. And then, as was mentioned, if they had symptoms when we saw them, we tried to get a EGD or upper endoscopy and a lower endoscopy of the colon with biopsies to try to get a better understanding of what was going on. So from that evaluation, we found a few things that were interesting, but the first thing is that autoimmune enteritis was actually not very common. We found it in less than 10% of the patients. One would expect in an autoimmune disease that perhaps the immune system would be attacking the GI tract, and we didn't find that very commonly. This is an image from a patient who did have that, and all those brown dots you're seeing are T cells, which are abnormally present and basically causing inflammation and causing symptoms to this patient. But overall, this was not a common occurrence we found. And the other thing we found was that pancreatic insufficiency was also not common, and this is where the pancreas, which normally produces enzymes to help digest food, doesn't do that, probably because of autoimmune attack is the most likely reason, and without those enzymes, patients don't absorb fat and have symptoms. And the way we diagnose that is that we check for pancreatic elastase in the stool. So if there's not any in the stool, that suggests that the pancreas isn't making it. And then if that's the case, we'll give them oral pancreatic enzymes, and if they get better, that's very suggestive that that's what they have. And then often we can see a pancreas that's very small or atrophic here, and you can see that arrow, that little, the pancreas is supposed to be much bigger than that. So that's why we think it's being attacked through autoimmune mechanisms. So what we did find is many patients had what we found was small intestinal bacterial overgrowth, or SIBO for short. And that's basically where the small intestine normally doesn't have much bacteria, or if any bacteria, and we find a lot of bacteria growing there. And the way we find this out is that patients would tell us very early on that they had antibiotics for a lung infection or urinary tract infection or something, and they noticed that their diarrhea got better. And that kind of led us down this path of finding out that this was fairly common in our patients. And the way we made the diagnosis, there are a couple of ways. One is to do a quantitative duodenal culture. So that's during an upper endoscopy when they're doing upper endoscopy, the gastroenterologist squirts a little normal saline and sucks it up and sends it to the microbiology lab, and they see if there's bacteria there, and also if they're capable to do it, see how much bacteria is there. And if there's more than a certain amount, specifically the amounts there, that's makes the diagnosis of bacterial overgrowth. Another thing that we can do is a hydrogen breath test, and some of you have probably done that, where you drink a sugar solution and the bacteria digest the sugar and produce hydrogen gas and other metabolites that we can measure in the breath. And the timing of those peaks can help us determine if they have hydrogen, if they have SIBO. And then another way, if neither of those tests are helpful, is to, if we suspect that's still the case, to give them antibiotic drugs and see if they get better. And that can be very suggestive as well. So, I told you that this SIBO is very common in our APECED patients, but is it really the cause of their symptoms? And I'm going to just give another example of a case that I think is very helpful. This was a man who had APECED, and he had very chronic diarrhea, 6 bowel movements a day, and he was not doing great. So we were concerned about SIBO, like I mentioned. So we did a duodenal aspirate, and we found that before they do the culture, we can look under the microscope to see if there's bacteria there. And we did see some bacteria there, but unfortunately, it didn't grow anything. That is a little bit of something we're working on to try to get more sensitive methods than culture, such as PCR. But we were, he didn't grow anything, but we were still concerned that he could have had SIBO. So this is what happened next. So what I'm showing you here is a graph of the amount of fecal fat, so how much fat is in the stool, and you can see at the bottom that orange red line is normal, of less than 7 grams in a 24-hour period, and he had very elevated levels, as you can see, is up to 100. And he also was very symptomatic, like I said, having a lot of diarrhea every day. So we were concerned that he had bacterial overgrowth, so we ended up treating him with 2 months of antibiotics with these 2 drugs at the bottom, metronidazole and rifaximin, and he had a very dramatic response. His symptoms almost went away completely by the end of it, and you can see his fecal fat numbers came down. Unfortunately, after he stopped taking the antibiotics, within a week he recurred. He had new symptoms, and so we treated him a second time with the same course of antibiotics, and he also responded again very well, and his fecal fat numbers came down. So I think the fact that his symptoms got better with antibiotics and got worse after, and it happened a second time, is very, to us, proves that the bacterial overgrowth is what's causing his symptoms. We also learned that this is a great example of relapsing, that a lot of patients, unfortunately, have symptoms recur after taking antibiotics, and we have to sometimes try different combinations and different approaches and kind of tailor things to each patient. Not everyone works the same, and that's something that's seen in also small intestinal bacterial overgrowth overall in general without APECED, and it's a difficult disease sometimes to deal with. So I'm just going to close here with our proposed algorithm, how to approach a patient if you're seeing, how to diagnose someone with APECED who comes in with these kinds of symptoms. So, first thing is trying to figure out what kind of type of dysfunction they have. Is it more constipation or diarrhea? Are there connections with food, suggesting, for example, worsening symptoms with greasy food suggests fat malabsorption? Next, we recommend getting stool studies, so specifically fecal fat and pancreatic elastase. So if the elastase level was low, like I mentioned, that suggests pancreatic insufficiency, and we would recommend trying the patient on enzymes to see if they get better. And if possible, the next step we would recommend is to get an upper endoscopy, and that can during their procedures, they can get a biopsy, and that can help make the diagnosis for autoimmune enteritis. And if that's the case, although that's uncommon, we do see it, and we've found through our experience that mTOR inhibitors, drugs that inhibit that pathway, have been helpful in those patients. Also, during the same procedure, they can do a duodenal aspirate with culture to look for SIBO. And if that's not helpful or not possible to do an upper endoscopy, then a hydrogen breath test, like I mentioned, is another way to make the diagnosis. And lastly, empiric antibiotics if none of those other tests are helpful. And overall, we found that with this approach, we can help most patients get some improvement. So I'm going to pass that along to Theo Heller.
Thank you.
Now we're going to talk about the most important organ in the body. Not the thymus. What I'm going to do, because of this term autoimmune hepatitis, I'm going to talk about autoimmune hepatitis a little bit, and I'm going to teach you a little bit about what it actually is. And then we're going to look at APS1 after you have some understanding. And this is a very conceptual clinical approach. I'm going to try to get, although Jennifer asked me to talk about biochemistry and molecular biology and all those things, she really pushed me hard. I said, no. And I'm also very grateful. She said I could have an hour and a half. I did. Okay, this is home. This is my bedroom.
Theo, I am going to ask you to talk into the mic because that's not what we recorded.
Okay, I'll talk into the mic.
Thank you.
Yes. But I'm not standing behind the podium.
Okay, fair enough.
So, this is where we live. You've heard about it already. I didn't know the picture was going to be shown already. This is to show you that some federal employees are at work when the sun sets. It's a view from my bedroom across campus, because I know you think we just drink coffee. So, what is autoimmune hepatitis? Let's talk about it a little bit. We're not really sure. We don't really know what it is or how it occurs. It's an inflammatory progressive disease of the liver, right? It's where the immune system attacks the liver. And it's probably a collection of a number of different diseases. It's probably not one disease, but we lump it together. And it can present in a very, very variable way, and there are different forms. There are variable forms as well, and I'll explain what I mean by that. And there isn't a specific test. There are tests that are suggestive, and we'll talk about them, but there isn't one test that really makes you say, oh, this is autoimmune hepatitis. And actually, there's a diagnostic scoring system. You put together a whole lot of things, and you get points on the system, and if you have more than 13 points, probably yes, more than 15 points, yes, and so on. So we don't have like here's the gene. It would be nice. 1 to 2 cases per 100,000, sound familiar? Women to men, about 4 to 1. And it occurs across all ethnic groups all over the world. And the peak incidence is between age 16 and 30. So there's another peak later in life, but the main peak is that age. And the classic presentation is a young woman, very high enzymes, very aggressive disease. But more recently, a more sort of indolent course has been described in older patients. And the classic presentation is that they have abnormal liver enzymes. And a lot of doctors call them liver function tests. They're not function tests. They're kind of enzymes. They reflect the mood the liver is in. I can explain more if you want in a bit, but I'm not going to now. Usually the patients are asymptomatic. Sometimes they have fatigue. They can have joint pain. They can be miserable. And often present as an acute hepatitis. Acute means it's sudden, just happened now. Chronic means long term. And some people will present with fulminant hepatic failure. They come into the emergency room, they're yellow, they're not thinking clearly, and they end up getting a transplant. Or sometimes they respond to steroids. And about 25% of people who present with autoimmune hepatitis already have cirrhosis. So in case you're wondering, cirrhosis is bad. I know you weren't sure, but it's not good.
And this is a good reference if you want a reference. I mentioned it in Toronto. And they're comorbid associations. Comorbid means occurs with. So let's list some of them. Autoimmune thyroid disease, Sika syndrome, rheumatoid arthritis. That was for you. Who studies you? Type 1 diabetes, vitiligo, ulcerative colitis. So these are sort of autoimmune conditions, right? These celiac disease, it sounds like it should fit, right? It sounds like we're at home. This is the right kind of place to be talking about this disease. The problem with liver disease is because we don't have a nice test for autoimmune hepatitis, there's this thing called the differential. There's a long list of things we have to consider. Other autoimmune liver diseases overlap. I'm scared of her. She remembers everything.
Yeah.
Overlap syndrome, other forms of hepatitis, other genetic diseases. This is very important. Drug or toxic disease, very important. And then alcoholic and non-alcoholic. Oh yes, thank you.
Now we're never getting involved.
No, that was a big mistake. You should never have done that. You set me free. Okay, alcoholic and non-alcoholic liver disorders, they clump together because they look the same. And it's a nice thing because I can swear I'm not drinking. It's just the fat in my liver, but it's hard to tell apart. Right? So we're going to come back to those things. We're going to talk about those. So really, autoimmune hepatitis can look like almost all liver disease. It's a problem. There are differences, though. There used to be the system we used to talk about autoimmune hepatitis type 1, type 2, an overlap syndrome with sclerosing cholangitis. You'll see this in the literature. You'll see this on the intertubes, interwebs, right? If you go look, yes, I know you. And there are these antibodies, right? Anti-nuclear antibody, LKM1, SLA, and then an increased immunoglobulin level. And there are certain patterns that we see. So ANA is almost 100% in type 1. LKM is almost 100% in type 2. The overlap is a little bit less, but you can see almost all of them have auto-antibodies. Is a very common feature, right? That's one of the key things in terms of the diagnosis. This is what a liver biopsy looks like. This is a very beautiful thing. And this saddens me a lot because you see all these blue cells, they shouldn't be here. These little, lots and lots of them, that's inflammation. Those are cells invading the liver and attacking the liver. It gives me pain. You should feel it too. And this is what happens if you don't treat that. The blue in this slide is fibrosis. And cirrhosis, by definition, is two things. You get nodules. Here's a nodule. And it's surrounded by the blue, which is fibrotic bands, called cirrhosis. So when you have the two together, that's cirrhosis. And you told me cirrhosis is bad. I remember. So what's published from the group in London is that autoimmune hepatitis type 2 can be part of the autoimmune polyendocrinopathy candidiasis ectodermal dystrophy syndrome. The liver disease is present in approximately 20% of cases. The problem is there's not a lot of literature. The problem is mostly case reports, small reports, short series, things like that. And in the literature, there are fulminant cases which are very unfortunate because they're not pedigreed. A lot of the drugs people take, like azoles, can cause fulminant hepatitis or significant elevation in liver enzymes. Steroids can cause fat in the liver, and non-alcoholic steatohepatitis, and you can get liver enzyme elevations too. So a lot of the older literature is not well pedigreed. And by pedigreed, I mean they didn't really look at all the patients and say, oh, they didn't have this, we thought about this, it's for sure this. So if you want to be rigorous and call it autoimmune hepatitis, you have to make sure it's not anything else. I try to get away with things, but Dr. Michail does not let me. So let's talk about our study. So first of all, I want to start with a thanks. I want to thank all of you because we couldn't do anything without patients, right? Not possible to study diseases unless people are willing to come in and do things. It really makes a difference. It's like an actor all alone. Right? It's a line from The Doors. Does anyone know The Doors? Anyone? No one? The Doors?
yes.
He knows the doors. I went to Jim Morrison's grave in Paris. Do you know Jim Morrison, the lead singer of the Doors? And he's interesting because he got naked on stage. I'm not going to do that. And he had to go to Europe because there were obscenity charges filed against him. And so I went to his grave, and there were these two women drunk and crying on the grave. This was like 30 years after he died. Anyway. So Lionakis, Dr. Wiener, all the fellows, there have been multiple fellows involved with the study. I particularly want to thank Elise, Mukil, and Stacy Rose, and Monica, who are most involved. And very important for a hepatologist is to have a pathologist you can rely on. We spoke about making the diagnosis accurately, and I think we're incredibly fortunate to have Dr. Kleiner. You saw his picture earlier. So the usual things, all the patients at APS1, consecutive patients, we didn't select, we didn't leave out anyone, and they were all evaluated per protocol. So everyone got exactly the same evaluation. So this is an overview. We stopped at 43 for a number of reasons. We're still seeing everyone, but for this analysis, 18 or 42% had what we're going to call for the moment autoimmune hepatitis. 72% were women, so that's 3 to 1. The liver enzymes, when we saw them, were normal. There's no difference between those who had and who didn't. Phenol, just a slight difference. But those who had elevated enzymes, ALT is a marker. It's not a liver function test, it's a liver enzyme. About the same, but the problem is when we saw people that already had the diagnosis and they're on treatment. Alkaline phosphatase was different. And in traditional autoimmune hepatitis, alkaline phosphatase does not go up. So this was interesting that it seemed higher, and when we corrected it for age and gender, because there's variation with age and gender, that is the only difference that we saw between the autoimmune hepatitis group and those who didn't have it. The alkaline phosphatase was much higher. That's not typical for autoimmune hepatitis. These are liver function tests. The liver has to clear bilirubin, it has to make clotting factors, and platelets are intimately involved with the liver. And what was interesting is there were no difference in any of those. No difference in any of the true functional assays. So the liver's doing its chores, taking out the trash, doing its homework, making its bed, all those things. So it seems like it's milder. Remember I told you 25% of cirrhosis in traditional autoimmune hepatitis? It seems like it's milder, but maybe we've got people earlier, maybe we've got people younger, everyone was on treatment, maybe it's a different disease, maybe it's not autoimmune hepatitis. What about the serology? Remember that picture I showed you before with all those auto-antibodies? This is very different. Statistically, there's no difference in the ANA between those who had autoimmune hepatitis and those who didn't. This is the whole group. This is those with and those without autoimmune hepatitis. And none of the patients had any of these. That doesn't fit, right? That's not the same at all. Remember, there's 43 patients. Looks different. So what about associations? Remember I showed you that long list of autoimmune diseases that go with it? So we could start with so again, same concept. This is the whole group, autoimmune hepatitis and the non-autoimmune hepatitis. So the Addisons and the hypopara, none of them were statistically significant. Let me just say that up front. But look, Addisons and hypopara, here's the CMC, I know it's not autoimmune, or maybe it is, I don't know, I don't understand. But I put it there just to be complete. And then if you look at all the others, the diabetes, the pernicious anemia, the pneumonitis, the hypogonadism, there's no difference, which was a surprise. And when we plot it, those looking to see who had any autoimmune disease versus none, this is the whole group. This is those with so-called autoimmune hepatitis, and this is the non-autoimmune hepatitis. No difference. It doesn't fit. It doesn't fit cleanly. And I love this slide because it's got lots of numbers. Lots of numbers. So there's a guy in Sweden who specialized in measuring all sorts of auto-antibodies, and to me they're just numbers and letters and things. I don't really know what they mean. But on this side, they're the letters, the different things he measures, and in red you can see that there are differences. So I've been painting a picture up to now that maybe it has nothing to do with the immune system, not autoimmune, but when we look at a different set of antibodies, there clearly are differences. There are none that you could use diagnostically. So let me explain. This is the test done. This is autoimmune hepatitis. And here I've changed the name. I'm saying APECED-associated hepatitis. I'm no longer calling it autoimmune hepatitis. And this is those without. And this is a p-value. That's the probability that this is due to chance or that it's real, causal. Not associative, I shouldn't say causal, associative, sorry. And the red means that it meets criteria, that it's not just due to chance. And you can see there are tests which are different. So again, so is it that there's inflammation in the liver and then these proteins get exposed to the immune system and you make an immune response? Or is it that there's an immune response to these proteins and then you get the inflammation in the liver? I don't know. You'll have to invite me back in 3 years when he's explained it, and I'll tell you. But so I don't know that, but there are differences, none of which you could use as a marker, because to be a good marker, you'd want something to be 100% in one and 100 and 0 in the other. We don't have anything like that. If you look at overlap, how would this help you? This is statistically significant, but 13 of those with autoimmune hepatitis, so-called, have it, but 8 of those without don't. And 9 of them with the hepatitis don't have it. So there's nothing, even although it meets statistical criteria, there's nothing that you could take home. Bank. So this would be helpful. What about the biopsy? So this is actually an APECED patient, but I'm going to contrast it with that patient I showed you before. So it's a different stain, but you can see all those blue cells here too. It doesn't look different. I'm going to tell you something that you can't repeat. In some ways, the liver's kind of a dumb organ. It doesn't matter if you give it alcohol or copper or iron or fat, it gets inflamed. It only knows one response. So imagine whatever my wife says to me, I just say yes. It's kind of like that, right? The liver just gets inflamed. It doesn't know how to respond in different ways to different things. So the fact that you see the inflammation here doesn't really help you. Yes, it's the liver. It's kind of dumb. It just gets inflamed. So we looked at the liver biopsies, and a number of people tried very hard. David Chaska, who I didn't mention, Rabab Ali, incredibly hard to track down these biopsies because they were all done before patients came to the NIH. And we had 18 biopsies. And what's really important is that 2 did not have autoimmune hepatitis. 1 had fat in the liver, probably from excessive amounts of steroids, and 1 had a drug toxicity. So not all elevated liver enzymes in APECED, 2 out of 18 is not nothing, are autoimmune hepatitis, so-called. Then there were 2 patients who we thought had autoimmune hepatitis but did not have liver biopsy, so they're included in the 18. That's how we got to 18. 9 out of 16 biopsies that we could score had severe inflammation. I already spoke about that. And when we looked at scarring, we score scar tissue in the liver from 0 to 6. 6 is cirrhosis. Only 1 had a 3 out of 6. And remember I said when they present in normal autoimmune hepatitis, 25%, 1 in 4? So that's 1 had a 3 out of 6, was halfway there out of 16. What about the microbiome? So I don't know, how much, do any of you know about the microbiome? How much do you know about the microbiome? So within you, there are trillions of bacteria who are your partners. Your job is to walk around, keep them warm, and feed them. That's your role in life. And what they do in exchange is they metabolize food, they make vitamins, micronutrients, have an incredibly important role in terms of energy metabolism. One of my favorite things is that they love calorie-dense food. And if you eat a lot of calorie-dense food, they get used to it, and they send hunger signals to your brain. So I tell my wife, when I go to Wendy's, it's not me. It's the bacteria. It is. So, but they're very important in all sorts of diseases, and you might have heard of it recently. Autism was in the news, anxiety's been in the news, all sorts of things. So how brilliant is this? I want to be called Slackia. There's a type of bacteria called Slackia. Wouldn't you know that they're the ones causing problems? They're higher in autoimmune hepatitis. So we do find differences. And we find 2 others, Ruminococci and Lactobacillus, are higher in those who don't have. So it may be that there's some are protective, and it may be there's some that are not as protective. That has to be explored further. One of the important things about these bacteria, they metabolize bile acids. Bile acids is very important in terms of a lot of things, but we didn't see a difference in the bile acids. Just briefly, treatment. I put this up to show you that there are lots of different approaches. Prednisone, 6-MP, or azathioprine, combination, cyclosporin, mycophenolate, tacrolimus, and whatever people got, they responded. So it doesn't really matter how you treat it, you can get rid of the inflammation. And the important thing is that it's not just the enzymes going down, I think the patients really do respond. All respond. So what can we say? It looks a little different. Maybe not really autoimmune hepatitis. Maybe we should call it APECED-associated hepatitis. They do well with treatment. There's lots to learn and to understand. And if you really want to know, watch this space. See you in 3 years. I showed this slide in Toronto. I wanted to show it again. This is my son fishing. And you see, he got up at dawn and he went and he caught a tiny fish. So last time I said, we're just starting, we're just beginning. Right? I think we're further along. The fish is a bit bigger.